afternoon. Good afternoon, all. To the last session of the Foundation Course in Palliative Nursing. Today we are going to discuss on end-of-life care and medical ethics. We do have our faculty joined us, that is Lieutenant Alice Stella Verginia. Welcome, ma'am. As all of you are familiar with her from the previous few sessions, I think there is no need of further introduction for her. Without much delay, handing over to her for the session. Over to you, ma'am.
Thank you, Sini. I hope I am audible, right?
Yes, you are, ma'am.
So, good afternoon to all the participants and welcome to my session. Today we are going to have end-of-life care and medical ethics, which I will combine and tell whenever I'm passing by through one of the slides. And of course, a little bit of grief, loss and bereavement. Okay. So, we are not going to waste our time. I will just start taking. So, what is end of life care? When you hear about what end of life care, what is end of life care? I just would like to know if someone could answer to this. What is end of life care? Anyone? You can put it in the chat. Yeah. No, we can't hear you, Mehboob.
Mehboob, ma'am, we can't hear you.
Yeah. Okay.
I think there is a problem with your microphone. Can you please check your headset? We can't hear you, ma'am, clearly.
Hello.
Yes, you are audible now.
Yeah, we are saying we are giving farewell to the person from this life.
Okay. So it's just a scenario. It's a resuscitation scene. A man of 89 years old with end-stage congestive cardiac failure. And the daughter, she reported saying that multiple times they have injected him, struck the femoral artery for blood gases, tried 4 times to place central venous catheter, performed chest compressions for an hour, pushed a breathing tube into his trachea and shocked the man's heart. Shock in the sense they gave DC shock and finally pronounced him dead. Okay. This one, someone has witnessed, the own family has witnessed this, saying they saw what was happening over there, and finally they pronounced him dead. Can you just tell me whether this death is a good death or a bad death? You can put it in the chat box also. Is it a good death or a bad death? Anyone? What do you think of this? 89 years old man. Multiple times he was given injections, femoral artery punctured, central venous catheter that tried to place, chest compressions given, push breathing tube into the trachea. You all must have witnessed also this one, है ना? कभी तो आप लोग ने ये देखा होगा. And finally pronounced him dead. I think one answer has come. Let me have a look. Bad death. That is by Sylvester Wamberg. Very good. Yeah, not a peaceful death, Anusha. Very good. Yeah, that was not a good death. It was a very bad death. And we all must have witnessed also such a death. When we see 89 years old man with the end stage of congestive cardiac failure, including me, I have witnessed also many times this has happened. Okay, so now let us see. What are the principles? Ensure patient's comfort through appropriate symptom control. When a patient is in end of life care, and especially with a life-threatening disease where we know cure is not possible and the patient is slowly moving to death, we need to do what we have to do is control, means symptom control is very important. We have to control his symptoms as far as possible in appropriate way. Avoid unnecessary interventions. That is very important. Review all medicine symptoms regularly. If they pay for day 1, day 2, day 3, day 4, for how many days the patient is going to be with you, we have to review the medications and the symptoms regularly. Maintain effective communication with the family members also, not only with the patient, but the family member. And ensure support for the family and the caregivers. That is very important because the family and the caregivers both are the ones who are looking after the patient. So we need to support them because they all are anticipating grief. Because before death, everyone anticipates grief. Grief in the sense that loss, they know the very next minute that person is going to die. The patient also, if conscious patient knows that I'm not going to be there for a long time, I'm going to die. Okay. So ensure support for the family and the caregivers. Usually the common symptoms what we come through the end of life care, and especially if you take a cancer patient, the cancer patients do have multiple pains in the body. So they will have pain. They will have that noisy breath. If you see their breathe, there will be a pattern of changing. There will be a noisy breathing as if the secretions are collected in the throat. Patient will be restless. There will be myoclonic jerks like this. They will have jerks, very restless, moving in the bed. Some people have nausea and vomiting. Some will have incontinence of urine and motion. Towards the end of life, some people, they will have difficulty in swallowing, become very malnourished. Some will develop pressure sores because they won't be able to move on the body, move in the bed properly. And of course, in some emergencies like stridor, they will have seizures. They may have massive bleeding. So these are some of the very common symptoms. And of course, pain, sometimes difficult to assess by conventional method. I have come across a person saying that he's having pain, but he was not resting on the bed. He was just moving here and there. He was, when I asked his son said he's saying he had pain. So when we asked, he said he wanted to go to the toilet. Then he ran to the toilet. He came and he was so restless. And finally, within that 10 minutes after time, he just came and lied down, and we can see he has gone. Okay. In the pain, WHO analysis ladder, it has been taught to you. So we have to go according to the WHO ladder. Trial of higher dose of opioid if already on opioids. If the patient is already in opioid and still complaining of pain, then we have to see for the higher doses, and beware of the delayed renal excretion in a dying patient. You very well know when shutdown starts happening, urine will be delayed, means excretion will be delayed. And when we talk about breathlessness and noisy respiration, shallow, frequent breaths with reduced tidal volume and a period of apnea, most of the time the family will tell you that we were just looking at him, then he started taking a fast breathing, and after some time, slowly, then we cannot see him breathing. Suddenly the breath has stopped, and they thought the patient has passed away already. But after that, they can see again, he will start taking breathing. So the pattern has changed, right? But you all must have witnessed that. And death rattle, it is nothing cooling of the secretion in the throat. Even if you do suction also, the same voice sound will come. So please don't do suction. Instead of that, put the patient on a side-lying position, and with a gauze piece or with a cloth, they can just clean the secretions. Okay. Explanation and reassurance is very important. Tell the family member, even if we do the suction, there won't be any good result of it. Instead of that, putting the patient on a sideline position will be better. Of course, sometimes morphine helps in reducing the breathlessness. Okay. And of course, to reduce the anxiety of the patient, we can give drugs like benzodiazepine. And of course, to reduce the secretions, glycopyrrolate is used. So that is very important, that glycopyrrolate is a very good drug to reduce the secretions. Restlessness, of course, the patients will have restlessness. We need to find out why the patient is restless. And of course, in terminal delirium, remember last week I taught about the terminal delirium. In delirium, usually when it is in the terminal stage, it is irreversible. We cannot do anything. Only thing is we need to manage it, reassuring the family members and manage the symptoms. And if the death is not imminent, if it is reversible, we can treat the cause. So as you all know, the drug of choice is haloperidol. Last time I told you the drug of choice is haloperidol. Another one thing is nausea and vomiting. Some people start nauseated. They feel that nauseated feeling. Some people will vomit. And sometimes the cause is not clear also. Still, we can give haloperidol because haloperidol acts on both things. Haloperidol is a very good drug for vomiting also. Okay, so we can give a haloperidol. And remember one thing, the route of administration towards the end of the stay, subcutaneous will be the best route of administration, because to access an IV line, it will be very difficult. And it will cause more pain, more problems also. Suppose they take home the patient, it will give a lot of problems. So if you give subcutaneous, that will be better. Dysphagia. Most of the patients will complain of dysphagia. When you ask, they say they won't be able to swallow because of the muscle weaknesses. And explain to the family member not to give anything orally that time. Okay, if the patient is refusing, the patient is very weak to take orally, not to give orally because there will be risk of aspiration. But that is one thing. Second thing, when the patients reach the end of life care, most of the time, they are not hungry, they are not thirsty. The people whom we are looking after, we feel that patient has not taken anything for 1 day, 2 days, 3 days. They are hungry, they may be thirsty, but it is not like that. Of course, the lips will become dry. Ensure mouth care, that is very important. Oral care you have to ensure. And the second thing is just wet the lips with water. Okay. And if there is some causes like serostomia or candidiasis, please treat that causes. Okay. As I said, mouth care very frequently, regular mouth care has to be given. Antifungal treatment if there is a fungal infection. And of course, appetite stimulants and artificial nutrition do not improve the situation. They may tell you pass a rice tube. They may tell you, why don't you put a this one IV fluid for the patient and all. But towards the end of life, that situation is not going to improve. Instead of that, if you give IV fluids, it is going to accumulate in the peripheries. Okay, and the patient will start swelling, because once there is a renal shutdown, where that water will go, whatever IV fluids we are giving. So it is going to collect somewhere. Maybe the patient will have pulmonary edema, the periphery edema and all. So as far as possible, try to avoid it. And the main thing is explaining to the family member about this. That is the main thing. Pressure sore, the patient may develop pressure sores towards the end. So if the patient is in the hospital or at home, ensure that the patient is always slow, maintain the position to prevent pressure ulcers. Okay. Otherwise, we can teach the family member to use a air mattress or water bed. Tell them if the patient is going to be in the same position, he may develop a pressure ulcer. That also will give pain to the patient. So we need to shift the patient's position in a better comfortable position. That is one thing. And do not pain the patient. Do not give discomfort to the patient. If the patient is having incontinence of urine and stool, which is distressing both for the patient, you can use diapers. If the death is not imminent, catheterization can be done. Okay, suppose you know the patient is going to go within 1 or 2 days, better not to catheterize. But if you feel patient is having a distended bladder, there is retention of urine, a simple catheter put and remove the urine, because the patient will have pain even if the patient is in a very end of life care. That is very important. In some patients, I know about my mother, she had retention of urine towards the end. So we had to put a catheter and to remove the urine. Emergency situations like striders, seizures, hemorrhage, we have to manage, especially because it is irreversible. If you are able to, assess everything properly, better to manage the patient. Okay, so severe bleeding is covered with dark covered clothes. Okay, so that visual impact of the bleeding will be covered. Okay, explain to the family member why the patient is bleeding now. If the patient is to reduce anxiety and control seizures, benzodiazepines has to be used. Psychological support for the patient and the family is very important, especially when the patient is severe bleeding and we are trying to cover with dark colored clothes and all. They will think what these people are doing. Why don't they give some injections? Why don't they? So they'll have a lot of questions in their mind. So anticipate these things before and please explain to the family member, especially head and neck cancers. If there is a cancer growth in the femoral area and all, just explain to the family members that anytime the patient will have a blast of the main arteries and the patient will start bleeding, we can only do what we can do is to cover that spot with the dark color clothes, that is masking the bleeding. Okay. Apart from that, there is not much to do for the patient. Okay. Our support has to be there for the patient. And this has to be explained to the family member, because suddenly the patient starts bleeding in emergency. What they will do, they will put the patient in an ambulance and they will bring to the hospital. And before the patient could reach to the hospital, the patient will pass away. So, right from the time the patient and the family is with you, we need to explain to the family member and anticipate that the patient will have anytime bleeding means what to be done at home. That is very important. There are a lot of controversies or use of analysis for pain management about artificial nutrition. Yeah, pain has to be managed till the end of life, because till the patient is alive, the patient will suffer pain. Patient is perceiving pain. So we need to address pain. Artificial nutrition, hydration, and blood transfusion. Now, artificial nutrition, hydration, and blood transfusion. End of life care, as I said, we have to think about these things. When we talk about artificial nutrition, okay, whether it is going to be, so here comes this one, medical ethics. So there are 4 points of medical ethics. Autonomy, beneficence, it means do good. Non-malfeasance, it means do not harm. And justice. Okay. Autonomy, beneficence, do good. Non-malfeasance, do not harm. And the 4th one is justice. Okay. Now, what it is? What is autonomy? Autonomy is nothing that it's our decision. See, suppose I decide that I don't want to go to hospital, I don't want to do any treatment. That is my wish. Suppose a patient tells you, please don't put a Riles tube. That is a patient's wish. You cannot force the patient. You can give the option to the patient, tell him that you are not able to take orally. We have to put a Riles tube so that we can feed you and your health condition will be better. And if the patient agrees, only you can do. But if the patient refuses, how you are going to put a Riles tube? So autonomy is something, it's a patient decision. The patient has the right to take decision about what to be done on his body. Okay. Now about beneficence and non-malfeasance. Now, artificial nutrition. Suppose the patient says, I don't want no IV fluids for me. Please don't give me anything. I can't do it. Yeah, my duty, my responsibility is that I have to explain to them that what this fluids and this artificial nutrition is going to do for him. Okay, maybe we'll have some electrolyte balance. So we need to meet it. So I can talk to them about that, but I cannot force a person for that. And especially in end of life care, artificial nutrition is going to be a burden. That is beneficence. When we talk about beneficence, it is going to be a burden for the patient because it is going to collect in the body in all the tissues, and the patients will have edema, pulmonary edema, peripheral edema. The patient will have breathing problems. So it is a burden to the patient. What we say, whatever is benefit to the patient, you do it. That is important. Now, let us talk about pain management. That is beneficial for the patient. Patient is suffering from pain. So continue with the pain management that you are benefiting the patient. There is no burden in that. Next, non-malfeasance. Do not harm the patient. How you are going to harm the patient? If you give artificial nutrition and hydrate the patient so much, giving blood transfusion and all things, you're going to harm the patient because it's not going to benefit for the patient. So do not harm the patient. Okay. Now, antibiotic treatment, whether it is needed or not, patient is already in the terminal stage and you're giving antibiotic. We have seen these things in our day-to-day life in the hospital. Now, what about terminal sedation? So terminal sedation, I don't know, when morphine pain management was taken for, you must have come to know about this one double effect. That is terminal sedation. Terminal sedation is nothing when the patient is very restless, agitated and all. We sedate the patient. Okay. So in some cases, there is a controversy. They say if you sedate the patient will die soon. Okay. But our intention is not to kill the patient, right? Okay. Our intention is to calm the patient, that restlessness, that agitation and all. Okay. Oxygen therapy in terminal breathlessness, how it is going to help? How many patients I have come across when we give, after giving oxygen also, the saturation is the same. It's not going to improve because the patient has reached the end of life care. And it's not going to help the patient. And the worst part is what, when we start the oxygen and give, the patient also will be looking at the oxygen, how much it is going. The family will be looking at the bubbles, how much it is going. And this side, one oximeter will be, we will fix up and they will see the saturation. Oh my God, it is still 60. You're giving so much of oxygen, still it is 60. With that anxiety only, the saturation will go down. In fact, now, when you are putting an oximeter, seeing for saturation, better please don't show to the patient and the family. That is the best thing to do. One patient has been admitted in a hospital and he was on continuous oxygen. A family member came and told me that they want to shift the patient to the hospital, and to the palliative care to continue with oxygen. I said, it's very difficult to continue with oxygen here. And would like to know. So he was saying that doctor already said the patient is in end of life care. Patient is a case of lung cancer in advanced stage. And he said, then I asked, okay, then what is being done for him? He said, continue oxygen is giving, we have put him the saturation also, but saturation has never improved. Actually, it is going down after oxygen also. So I said, yeah, this will happen. So he said, why? So I need to explain to him about the respiratory system. Okay, how oxygen exchange is done and blah, blah, all these things. Okay. So I said, there is alveol and all. I said, your this one actually is the parent's father. I said, your father doesn't have these things inside. Everything has been damaged. Okay. And there is no place for the exchange. And whatever oxygen we are giving, there won't be any improvement. So finally they said, okay, then in that condition, we are going to take him home because he wants to die at home peacefully. Sometimes we need to explain terminal breathlessness. Even if you give oxygen therapy, it will be the same. We need to think it's a benefit or it is a problem, burden for the patient. Again, it's going to be a burden. Putting a mask on the face, the patient will do like this, rolling. Even if you want to give oxygen, give with the prox. At least he won't, that face mask, please don't give. And discharging home. See, family has come and told you, asked you, family came and told you that it was my mother's wish to die at home and we want a discharge. Please discharge the patient and send home with all the instructions. How to take care of the patient, how to take care of the catheters, what to be done towards the end. And after the death of the patient, how to remove the tubings and all these things. Please explain to them and let them take home because that was the wish of the patient. So I hope you understand what is autonomy, beneficence, and non-malfeasance. Justice will come. Okay. So use of analgesic for pain management, drug of choice, again, morphine. Many people have the this one, fear of respiratory depression. Okay. But to control the symptom control, morphine we need to give. And in fact, morphine helps to reduce the breathlessness and the secretion. Okay. And careful titration, of course, we have to do. Artificial nutrition, hydration, and blood transfusion, cachexia and fatigue is irreversible. You cannot bring back the patient to a normal condition. It's a normal phenomenon towards end of life. When we come to the end of life, our systems are giving away. So please explain this to the family member. Patient doesn't need anything to drink or to eat. You can just wet the lips. Reassure the family and explain, of course, the problems of parenteral fluids. If you give a lot of fluids, what is going to happen? Please explain to them. Antibiotic, of course, no, because it's not going to cure your disease towards the end of life care. So please don't start antibiotics to the patient. Terminal sedation, patients who travel a difficult road to death suffered needlessly. Okay. End of life care, in some patient, you can say patients will be very restless, moving to this side, that side. And the person who was standing and seeing, they'll feel very bad. So explain to them. Terminal sedation we can give. We can sedate the patient so that the patient will be calm. But our intention is to just calm the patient, not to kill the patient. No. We don't hasten the process. This one. We don't hasten, we don't intend to kill the patient. Only thing is, it may hasten the process of death. That's all. The patient who has to die after 6 hours may die within 3 hours. That's all. And not in all cases also. So respond only to sedatives. But this also has to be explained to the family member, and if they agree, Okay, we can go ahead. Oxygen, I told you, there is no use of oxygen. And if they go on insisting you said, okay, we will start. It's just a trial. And if we find there is no improvement, the patient is in difficult situation, we will remove. But here, what you have to do is communicating to the family member about the benefit and the burden. And in their simple language, in their own language, please do explain. Maybe you have to draw the lungs and all and show them. Maybe you have to do it, but explain to them in their own language. And discharging home, that is up to the choice, autonomy of the patient. If the patient's decision was to go home, please discharge the patient. Don't do this lama, dama, and these things. Just do one thing, give essential medicines to the patient, essential drugs can be given, explain to the family member how to take care of the patient. And if there is any problem, please ask them to contact over the phone. And the awareness of the final situation event is very important. You can just explain to them, the patient will be withdrawn from the world. They won't eat, they won't drink, they'll be always sleeping, drowsy, not interested in the not interested in the world where they are living. So these things you have to explain to them about the change of the pattern of the respiration. You have to tell them and give a psychological support. So end of life care, when we talk, we ought to give those who are to leave life the same care and attention that we give to those who enter the life, the newborns. Don't you think like that? When we are born with all full, this one giving sweets, all are very happy. Okay. And when we are going, nobody is attending it properly. So death, birth and death, we have to give the same attention and care. And that is very important, because a dignified death we need to give where there is no pain for the patient. Patient is free of pain and he leaves this world peacefully. And the people who are leaving, they have good memories about the patient and the family. Now, when we talk about, I told you about autonomy, I told you about beneficence, malfeasance, and about justice. And what is justice? That's the fair use of the resources. See, in a hospital or in a hospice, maybe you are having a hospice of your own. Okay, even if you're having a hospital of your own, please, whatever resources you are getting from anywhere for that matter, use it properly for every patient. It's not that you know one of the patients and you will use everything for that patient, and a poor patient comes, you are asking them to buy it from outside. Very simple thing. When you have 10 catheters with you, use for all the 10 patients. Don't keep on one thing and ask them to buy. Especially for the poor patients, it's very difficult. So justice is that the fair uses of the resources what you are having. Whatever resources you are having, fairly use it for everyone. Don't deny that for one person. That is what justice you are showing. In many ways we can talk. Like you're explaining to the family member, to the husband, that your wife is diagnosed with the 4th stage of CA breast. And this is what she is. That is also justice, because maybe he need to take some decision. So show justice to the patient and the family. As a healthcare provider, you need to do this. Because when it comes to the end of life care, both the patient and the family, they are facing a lot of problems. Physically, psychologically, socially, and spiritually. Give full support to the patient and the family. Sit with them. Find out what are the psychological problems they are having, what are the social problems they are having, what are their spiritual problems. Maybe the patient is very emotional. He wants to meet his mother. I remember a patient with a big ascites patient had come. He wants to meet his, and here the people were very busy. Like they have sent the patient from the ward. They let us do the ascites tapping. And we were very sure we do the ascites tapping, maybe the patient will, patient won't be there anymore. And he was just explaining, he was saying, I want to see my mother. I want to see my mother. I just went and told our doctor, I said, please, doctor, we removed, of course, we removed about 200 ml, something this one, tapping done. And that was the time we started saying. So we said, please send the patient. So doctor, immediately we discharged the patient. He went home. He saw his mother and he passed away. Another case, I still remember another patient where the patient said he wants to see his mother, and from the hospital, they did not allow the patient to go. And saying this, the patient passed away also. I know a person who was holding my hand and she was saying, I'm going, I have not seen my son, I'm going. And she passed away. Till the end, she couldn't see her son, and the son couldn't see his mother. But of course, it was another situation because it was an army and the son was somewhere. But still, just think about that. It's very important. Autonomy. Family says we will take the patient to the home. And in the hospital, we say, don't take. If you take, you don't come back. So sign the LAMA against you are going, against the medical, this one. And this is my wish where I want to die. It is my wish whether what I have to do. For that matter, for anything, please take the permission of the patient before you start giving an injection. Please take the permission of a patient before you do the catheterization, but explain to them. If I don't do catheterization, urine won't come outside and you'll have more pain. Explanation is very important. If you don't explain and just go and tell him the patient refuses, he doesn't know what is the consequence after that. So that needs to be explained. So show justice to the patient and the family. Remember the autonomy, do good and do not harm the patient, and justice. These are the 4 ethical principles, medical ethics, ethical principles, cardinal principles that we follow in palliative care. And you need to know towards the end of life, what all happens to the patient. And that has to be explained to the family member because they don't know. They think patient needs to drink, patient needs to eat, but they don't feel thirsty, they don't feel hungry. So the final hours has to be properly managed because family members and caregivers will feel confident, and it's a final gift-giving good death and a sense of growth in all the members of the caring team. And if we don't do, patient will have endless sufferings. Family members will feel guilt about it. They'll be worried. Anyone come, they will say the patient towards the last minute, it was very bad. I remember one of my colleagues only, when our brother, he was in an advanced liver cancer, he was hospitalized. And that early morning when he was hospitalized, he had 1 or 2 bouts of blood he vomited. His condition was very bad. And everybody knows, everyone knew that he's passing away. And you know what happened towards the end? Because it was the early morning time, no? So he was brought to the hospital. So in the hospital, actually, they admitted him into the ward. And my colleague, she went to see him. And after some time, I could hear that my other colleagues, other friends, they said, we'll just go ahead now. I think something has happened over there. They all went. And what we heard was, the second person who had gone, what she saw was the patient had a cardiac arrest and they started giving DC shock. And this staff who had gone, she just shouted like this. She said, just let him go peacefully. And all were stunned. The hospital doctors and nurses who were giving, they were stunned. They stopped it. And well, you know what she said? She said, already he has gone. He was in a life-threatening illness, which can't be cured. Let him go peacefully. Why you want, after everything has stopped, why you want to do this DC shock and all? And my colleague, she was crying because it was her brother. So that guilt will be there in their mind. Whole life they will remember about that. So give them some good memories. So the take-home message is that review symptoms regularly and reassess the need of each medicine, whether this has to be given or not. And of course, only those medicines to manage the distress like pain, breathlessness, excessive secretion is there, patient is very delirious, vomiting. Only in these cases, you need to give medications. And choose the least invasive route. See, oral is okay. Okay, oral, buccal mucosa, subcutaneous. Intravenous, I said, no. Best is subcutaneous or oral. If the patient is able to take till oral, oral. Otherwise, if you have to give through sublingual and all, you can just make it a paste and give it. Some medications I told you last time. And of course, effective communication is very important. Keep on communicating to the patient and the family. That is very important. I hope you all can see this. One side you can see one lady is sitting with her, and the other side you can see all the tubings. Now I want you people to tell me which way you would like to go from this world. This one or this one? With all these tubings you would like to go, or without all tubings comfortably? Just put it in the chat box.
Without tube.
Without tube. Yeah, Marcela, without tube. So still time is there. I just want to, if you have any queries, we will have that. I want to just, without tube, Mamata, good Mamata. Just something about, I'm not going to go in detail, but just little some things I want to talk to you about grief and loss. I hope you all know what is grief, right? What is grief? What is grief?
When someone dies from our family, we grieve for that.
Yeah, very right, very right. When someone dies from family, we start, so we grieve for them. But remember one thing, grief starts before the death itself. Okay. So when a person comes to know that they are having, definition, loss is the absence of possession of person when we lose something. Okay. Loss. Grief is emotional response to the loss. So this can happen before. Remember that thing. Say one person can start grieving before only. Suppose we know somebody in our house is not well and in a life-threatening illness or end-of-life care or in an elderly age, and you know this person will slowly moving to death. And before the person goes only will start grieving, because you know after some time you cannot see this person. And same thing happens with the patient also. The patient also knows that I'm going to die soon, and they will start grieving. So that is called anticipating grief. Anticipatory grief it is. Okay. Mourning is what? Mourning is that outward social expression. We all cry. Now you have seen people crying and all. So that's the social expression that I have lost someone, and they start crying. And what is bereavement? Bereavement includes grief and mourning. Bereavement is something which gives them when they are in their, when they are grieving, and when we are going and meeting them, that loss and all, we are going, meeting them, and in that bereaved time, okay, that last time, okay, we need to visit the people, find out what happened with them. That is very important. So loss, you no longer have something which you had before, and if it is said that, it is permanent. Okay. So most of the time when something is lost, especially some people have given you a very precious gift. Sometimes maybe your mother, your father have given something. which you keep it very precious because it's very precious for you. And if you lose it, you will start feeling bad about it. And that is also grieving. Okay. And grief is natural and normal. It's a normal reaction to the loss. You know, if you take a majority of people, after someone dies at home, still they continue their life, right? And they are not going to stop their life now. They have to continue their life. Okay. But of course, remember one thing, we have come across in some cases also where one person has passed away and the second person also goes with them. Okay, that has also happened. Okay, because they were not able to accept that loss. Okay, so you must have heard like wife died and husband died within half an hour to 1 hour, like that. Many things has happened. Okay, and I have also come across so many things like that. But one thing was like wife died and the husband went and committed suicide because he was not able to accept the reality. Okay. So bereavement is the state of having experienced a loss, especially the loss of a significant person. And during the bereavement time, people show their grief, but it is very normal. It can go for some time, grieving. Okay. But after that, sometimes they start living. They have their normal life. They start adjusting with the situation where they start going for their job or looking after the children. It goes, but it doesn't mean that they have forgotten that person. No, they have not forgotten the person. Sometimes when they cook something, they will tell, yeah, this fish my father used to love so much. This cake he used to love so much. This was his favorite color. We still remember them. Okay. But that is not a grieving. We don't grieve, but we still remember them. That's a good memory for us. Because it's a normal reaction. Remember, after so many years, we still remember them. So now, recently, my father passed away a long time, almost 16 years. Okay. So when it comes, we will go to the church, we will pray for him. Maybe we'll cook something which he liked. So that are all the remembering them, keeping them in our memories, but we don't forget them. Okay. But that will be in a good way we are remembering. Okay. So grief is very personal and it's a unique experience, begins before death. It's a task-oriented life, not orderly or predict. We cannot predict also grief. Okay. Some people, after the death of the person, they will stop crying and all, they will start normal. Then suddenly everything will change. Then they won't be able to adjust with their life, with their routine, and they will be depressed. That also can happen. So one more thing is healing always occurs when the pain is less. Sudden death, like in children, it's very difficult. If suddenly something happens to the children, it's very difficult for the parents to overcome that. Sudden death, like in accidents and these things. Okay, that also is very difficult. So anticipatory grief, it is as I said, the grief starts before the death itself. That is anticipatory grief. So all the family members, even the patient, they all have this anticipatory grief. We have an uncomplicated grief. I want to just talk about something. Sorry. Yeah. One second. There it has gone. Oh, sorry, I think I have done. Okay, just leave it. I will stop sharing. The second is that is it's a normal grief, otherwise uncomplicated grief, which is a very normal. They may grieve for 3 months to 6 months, and it's very normal. They can even grieve maybe suddenly after 1 year, they remember that their father has passed away and mother has passed away, and they may grieve also, but it's very normal. But there's a complicated grief. In the complicated grief, what happens? They stop eating, stop going out, depressed, bad behaviors, their behavior changes, they have that destructive thoughts. That is all uncomplicated grief. It means a complicated grief. Okay. And there are a lot of risk factors for that complicated griefs also. A person who was an alcoholic and had a bad relationship with the family member. So when that person passes away and it was abused and all, okay. So that is a complicated grief. Okay. It can happen in many ways also in the complicated grief. The person has already passed away. Okay. And the family member, maybe wife or children, they cannot adjust with that. So day by day, their grieving goes in a bad ways. Won't get adjusted to the new situations. They won't be normal. They show all abnormal behaviors. All destructive thoughts will be there. So that's a complicated grief where we need to assess and manage it. And why we have to do this bereavement visit, that is very important. After the patient passes away, we still need to go and visit the family to find out how they are coping up with that. How the patient died, where the patient died, who was there around the patient while the patient passed away, and how they are coping up with that situation. Maybe you can help. Maybe you know before the death of the patient itself, the family member is very emotional and the family member was saying, I cannot live without this person and all. In that cases, we need to have more this assessment. We need to sit and talk to them. Because hopefully, if they become very normal, it is okay. But they may go for a complicated grief, it will become very difficult. Children, they won't study properly. They won't go to the school, starts bad habits because they are not able to overcome with the loss in their life. Maybe they lost their parents or something has happened. So that will affect their life. So in these cases, we have to be very careful. And that is why in palliative care, we say bereavement is very, very important. We need to go to the patients, visit the patient at home to find out what exactly they are going through. So remember this thing, anticipatory grief is before it starts. Normal grief, otherwise uncomplicated grief, it's very normal grief. Anybody will have that grief. But complicated grief is very alarming one. Because it will continue whole their life. Because they won't be able to overcome that or accept that. And that is very important. And that is why in palliative care we say, not only physical, psychological, social, and spiritual. Because the meaning what they are given for their life. There may be some events in their life which they have not, which they were not able to forgive. Otherwise, they want to meet someone to ask forgiveness. Maybe son and father doesn't have a good, relationship. But towards the end, father wants to meet the son and talk to him. Otherwise, the son wants to meet the father, where they want to reconcile. So here and now, what we need to do is we need to talk to the patient and the family. And that is right from day one. If we start talking, communicating, we'll get a lot of information which will help us for them to cope up with these things. Because everyone won't be able to cope up properly. As I said, the patient died and the third day, husband committed suicide, even after he knows that he is having 2 small children. One of our patient, our patient in the sense when I was working in the hospital itself, he said once he goes out of ICU, he will commit suicide. He jumped out of the this one, third story building jumped out because he was not able to accept the reality. So it's very important that we need to communicate with the patient and their families. And don't leave the family after the death of the patient. Just do some. And if you find out that this person is having little problems, so again, just visit them. They will feel more comfortable. They will feel more better if you go and talk to them. That psychological problems, what are the psychological problems they are having? What social problems they are having? Talk to them in the they ask them if their patient had some wishes like prayers, otherwise giving alms to someone, food to the people. Some wishes the patient must have made before his death, whether they were able to do it. Don't stop them. If they want to do it, they can do. And another very important thing is towards the end of life care, if the family wishes to call the chaplain or they want to do some puja or some prayers at the bedside of the patient, please arrange for that. Don't stop that. Let them pray. That is their wish. See, like we Christians, that last sacrament, in Hindus, they give that Ganga Jal. If you tell the Muslims, they come and pray. They pray something in the ears, they come and pray and all. Okay, so when you know about the culture, so culture is very important in our family. I mean, in end of life care. If they want to do something culturally, go ahead, let them do. They have that culture, their custom, their tradition. We need to allow them. Don't stop them. Even after the death of the patient, how to cover the patient. If they have that some culture, how to cover it, better ask them to do it. And that's why I still remember, a patient after the death of a patient, please call the family member or whoever is there and ask them, tell them that we are going to clean the patient. We need to clean the patient or not, because some person, they will say, you just give us, we'll take home, we'll give a bath, and they have their own way of doing for the funeral. Okay. So in that case, let them do. But if they say, okay, we would like to help you, well, welcome. Let them come and help us. So these things, we need to talk to them. If we don't talk, we won't be knowing what is their culture. You all know, in some culture, ladies are not allowed to even cry. Okay, they say that a person has to be sent peacefully from this world. They cannot go to the graveyard. In some this one customs, the dead body they won't bring inside the house. The dead body will be kept outside the house. We have to respect their custom, their tradition, their culture. That is very important. So wherever you are living, you may be knowing what is the culture of that area, that community. So follow it. If you don't know, just ask them. And be there always. The patient is finally gasping, don't leave them and run away. And after the patient dies, you can see only the dead body, that body is there, and their families are sitting and crying. All the nurses, doctors, all left. All have seen something. At least one person should be there towards them. That support has to be there when they are grieving, when they are crying. So these are the things that you have to remember towards the end of the life of a patient. Remember about the ethical issues that can take place. So keep communicating with the family member about the prognosis of the patient, the changes that can occur, and how to take care of them at home. About what is good and what is bad. Burden versus benefit. What is justice? What is the autonomy? Decision maker is very important. Decision making is very important. One elderly lady was brought in. So many people had come with them. Okay, so everything, and finally doctor said the patient has to be admitted. So they said, we don't have time to look after the patient. So we said, then in that case, we need one person. So the person who was standing next, he said, okay, we will just have a talk and come. Talking, hours went off. Still, they did not come to a decision. Who will look after the patient? Who will stay with them? And finally, the doctor said, so in that case, do one thing, you people can take. Because you people cannot look after your mother. You have to ask, your wife is asking husband, husband is asking wife, son is asking wife, daughter is asking her son-in-law, and all that, this one. Actually, our doctor, she felt very bad. She lost her temper also that time. And 3-4 hours they took, still they didn't decide what to do. And the patient was not in end of life care. She has to be admitted for a symptom control. So when a patient comes, find out who is the actual caregiver, who is going to look after the patient, who is going to look after and be with the patient, where they are going to take them. So these things are very important. Husband and wife came, wife was not well. I have so many things are there like that, I cannot forget her. So that man, he told me, he said, after the death of my wife, I know my wife is slowly moving to death. After the death of my wife, I don't know what to do with the dead body, it seemed. And I asked why, then he said, I don't have a place to take her back. He doesn't have a family. I mean, the family is there, but not in good terms. So I said, what was the reason? He said, I won't be going back to my country, in the sense that place. I want to give her body to the medical college. I said, then there is a lot of procedure to be done for that. So he finished all the procedure, and after that, the body was given to the medical college. Another one, that lady said, I don't know what to do because we are from different caste and we got married and there is no support. And my husband is from a higher caste. So after that, what to do, I don't know, because no children also. Thankfully, after a long conversation with the volunteers, I had a long conversation with their family members, especially because this lady, she has only her mother. Okay, no other family, extended family. So husband side, they said, everything is okay, but we won't allow that lady to enter the house. After his death, we are ready to take the body and do all the cremation, whatever is there. But she cannot enter because she is from a lower caste. So it was really a problem. And finally, we came to know that from that man's side, the patient's side, one person is patient's brother's son, one nephew. Secretly, he was helping a lot. So he said after the death of this uncle, he will take care of everything, what to be done and all. And that too, you won't believe. We need to find out. We were talking to everyone. Finally, we came to know one person is there like this. In another case, we tried talking also. They said nothing to be done. We cannot allow that lady to come with her children, 2 small children. They did not allow. And the fellow, he was very young patient and passed away. And actually, that he's from a rich family also, but they did not allow this, his wife and the 2 children. Still, they are living like that with great difficulty. She's a very nice lady. So many things are there. So please be with the patient and the family. If you have a good communication skills, you will come to know all the problems. You will be able to find out what is going through. You can support them. Give a good death, dignified death for the patient, so that the family member will remember, will have a good memories. And of course, always visit the buried family. That is very important. Just don't leave after a long time. Just don't leave once the patient has passed away, everything is finished. No. So that is for today. So I am concluding. Now, any questions? And as you all know, today is your last day. Okay. So we started with introduction of palliative care, a lot of things you have learned. And I hope you people will be able to, practice some palliative care in the place wherever you're working. It doesn't mean that you have to work in palliative care itself. In the hospital itself, in the wards where you're working, you can give a lot of palliative care. You can give good communication, have a good communication with the patient and the family. You can find out about their psychological problems, their social problems, their spiritual problems. That will work out. You can give good care, nursing care for the patient. That is also palliative care only. It's not that only palliative we can do. If you feel that I need the patient family's number, you can take, and after the death, you can just call them and ask them. I remember a patient has come from very far, not from our state itself. Like the 2-3 patients I had to him, I felt really, I need to talk to them. So I have spoken to them after the death of the patient. And still one of the patient's brother, he's in my mobile in the WhatsApp. He keeps calling me from Bihar. He's from Bihar. So that is it's a connectivity. Okay. So you can just, if they want to talk to us, you can just tell them. Any problems, you can talk to me over the phone. But give the time, tell them. See, these are the things. If they have doubts, they can call. So, any questions? I'll take the questions, or you can share your experience. Sister Winnie.
Thank you so much, ma'am, for that wonderful presentation. It was really enlightening and enriching. Any questions?
And don't keep the palliative care, whatever you have learned, don't keep it for yourself, okay? When you're working in the hospitals, please teach your colleagues and your friends also what you have learned. That is very important. Encourage them to learn about palliative care. That is another thing. No questions? Surprise? 36 people are there. Of course, at least 33 people are there. Sister Anita Mary said, thank you, ma'am. No, it doesn't mean if you have questions, you can ask. No questions means it is okay. So say what to do. You can give your feedback. I think there are no questions. So you can continue.
If there are any feedbacks to be given now, you can speak about the past 2 months. We were together for the past 2 months. And if you have anything to convey with us, this is the time.
Yeah, anything about the course or about the lectures or something, you can say, so that we can also improve. Naina Shukla, we agree with everything. नहीं, जो कुछ भी आप लोग बोल सकता है, ठीक है, ऐसा बात नहीं है, ठीक है. People come on, so many people are coming and taking up this training. तो कभी कभी है ना, हम लोग भी ऐसे होना, ऐसे लगना चाहिए ना कि हमारा ट्रेनिंग अच्छा है कि नहीं. That also we need to know. So if there is some ups and downs, if you tell, we can improve it.
Hello.
Yeah, sure, Mehbooba. 1 second. Learning materials need, ma'am, for improving myself. Anjala. Sini, hope you are looking. I'm personally happy to have been with you in this class. Thank you, sir. Yeah, Mehbooba, you can see, please say.
Yes, very good afternoon, ma'am. It was all a good lecture, but
Yeah.
in between some disturbance of voice was there.
Hmm.
It was echoing the voice. We couldn't hear it properly for a few seconds, a few moments. That only was the problem. But in altogether, the lectures were very informative, knowledgeable, and there were many things we were not knowing. That all we came to know. Thank you so much, ma'am. Thank you so much.
Welcome. The thing is, when there is an online session and when the faculty is speaking, what to say? The participant has to remember one thing: they should not mute their unmute their this one. What to say? Audio and talk. Many times, what happens when they do it, there will be a lot of echo, and we cannot. And they won't be able to hear properly. So maybe they must have not noticed. Suddenly they must have been talking to someone. So that has to be taken. Okay, 1 second. Ma'am, I have learned a lot. Have you any diploma course for palliative care? Okay, Anusha. We are trying for a diploma course, but how far it is going to, when it is going to come and all, we don't know. But of course, there are courses like fellowship is there in palliative care, but that are all this one offline courses. Okay, it is there. Very good sessions. Thank you. The offline courses are there, which you have to come and do it. 6 weeks course, which is offline. Now, what we people have done, we have 6 weeks course, which is offline, that you have to come in, so that you will have a direct interaction with the patients and all the what to say. You will be able to see the procedures, how it is being done here, and these things you can have a look. And of course, fellowship is also the 1 year fellowship. Of course, that is a distant course, but 1 month you need to be somewhere. 10 days you have to study. I mean, theory, you have to be there here. 10 days, it's offline. And 10 days you have to, 20 days you need to have a experience, once they will placement somewhere where there is a good palliative care, then you have to come and give the exam. That is also is there. So go through then all the palliative courses, you can get it. Yeah, of course, Sister Anita, it is very helpful to practice in the hospital. Usually we get a lot of patients from the hospital only, and when we explain to them, then they take a decision. Okay, now the condition of the patient is like this and why to keep, because many times it happens, even the doctor will say that patient's condition is not improving. This is how it is going to be. Okay. So now the thing is, the family member doesn't know what to do, whether they will take what decision they have to do. So we need to advocate for them also. So that is why communication is very important, to make them sit and talk to them, the condition of the patient. This is what is happening with the patient. And if they can take home and take care of the patient there. So when you explain, then they remember, then they realize, okay, now it is time for us to take us. So that is very important. I'm from Sri Lanka, ma'am. Thanks, Anusha Silva. Yeah. So these are the things that you have to keep in mind.
There are no more questions or comments. I think we can wind up the session.
Okay, thank you all so much. 1 second, Sonia. Thank you all so much, participants. And thank you for your listening. That is also the patient listening. Okay, and thank you all. Jessie, meeting with palliative care, Chai staffs. 1 second, Sister Jessie, you are from Chai? Can you unmute? Sister Jessie.
Most of the participants of this batch are from Chai.
Chai, okay. Because I have been in Chai for almost, I think, about 3-4 years continuously. I used to come to Chai to teach about palliative care. I used to be there for 3 to 4 days, and I used to take a lot of most of the sessions I used to take. Actually, after near to that COVID, somewhere around from 2000 19, I did not come to Chai. Otherwise, every year I had come to Chai for the training programs. Anyhow, thank you all so much. Bye, Sini. Thank you so much.
Thank you so much for being here with us, ma'am. Thank you so much. Thank you all for joining with us for the past 2 months. The journey has been wonderful for all of you. And the things that you learn from here, like palliative care, will help you in your future endeavors. Thank you all. And the feedback link and all the other details will be shared in your WhatsApp group. Thank you all for joining. Bye bye.